and welcome to the launch of Good Health Down South 2021 to 2025, a sexual and reproductive health strategy for the Southern Metropolitan Region. It gives me great pleasure to welcome you all here today. I'd like to begin with an acknowledgement of country. Women's Health in the Southeast, or WHISE, acknowledges the traditional owners of the lands on which we work, the land of the Bunurong peoples of the Kulin Nations. We recognise their continuing connection to the land, waters and culture. We acknowledge their elders past, present and emerging, and that Australia always was and always will be Aboriginal land. We acknowledge and pay respects to the many strong and resilient Aboriginal and Torres Strait Islander women who are disproportionately affected by discrimination and family violence, and that Aboriginal self-determination requires a systemic shift of power and control from government and the non-Aboriginal service sector to Aboriginal communities and their organisations. We commit our organisation to truth listening, truth telling, and bringing the Uluru Statement of our heart to our hearts. Welcome again to our wonderful partners and stakeholders to the launch of our Regional Strategy for Sexual and Reproductive Health, or SRH, and thank you all so much for joining us today. Today is not just the launch of our strategy, but a celebration of the first iteration of Good Health Down South, implemented from 2018 until 2021. And it's a celebration too of all of you, our partners and stakeholders, for the incredible generosity that you've shown us in providing extensive consultation, expertise, rich regional knowledge and networks for the renewal of our strategy. For those of you who don't know me, my name is Laura Riccardi. I'm a Health Promotion Officer at WHISE, and I'm the project lead for the renewal of Good Health Down South. I'll also be facilitating today's formalities. Before I go through our exciting agenda to you all, I'd like to remind everyone of some Zoom housekeeping. We encourage everyone where possible and where people feel comfortable to leave their video on, as it makes for a more engaging meeting that mimics the ambience of a real life event, which we will soon be holding, no doubt. A reminder to please keep your microphone on mute throughout to minimise background noise. Although we'll be moving swiftly through the agenda and won't have time or opportunities to engage in discussion and respond to questions, I do encourage anyone with any feedback, questions or comments to contact me at any time via email. My contact details will be included in the slide deck at the close of the launch. So to highlight the exciting and full agenda we have planned for today, including a panel of distinguished guest speakers and live musical entertainment, we're going to open the launch with an address from our newly elected Chair of the Board of WHISE, Kerry Bradley. I will then provide an overview to the strategy and our priorities for 2021 to 2025 and next steps for implementation. We are fortunate to then have a musical interlude from Alice Tovey, following which we'll have a brief announcement from the Promoting Respect and Equity Together project lead and my colleague, Katrina Nurse, following which we have some reflections from the outgoing Mornington Peninsula Shire Mayor and Councillor Despi O'Connor, and the Executive Director of the Multicultural Centre for Women's Health, Dr. Adele Murdolo. We're very privileged not only to have the presence of our guests today, but also to have their respective organisations' collaboration and partnership for the implementation of Good Health Down South, and WHISE thanks them for their leadership. Without further ado, I would like to introduce our first guest for today's launch, the Chairperson of the Board, Kerry Bradley. Kerry has over 20 years senior management and executive experience with a strong clinical background working in regulation, acute care across both the public and private sectors, rehabilitation and aged care. She is a highly skilled leader in managing organisational change at both strategic and operational levels. She has served on the boards of Breast Screen Victoria, BAPT Care, Victorian Cytology Service and Mercy Hospitals Incorporated, and as a member of the Finance and Audit Subcommittee of Vic Health. Kerry Bradley has also held ministerial appointments as a member of the Victorian Clinical Council and previous Victorian Quality Council. Please join me virtually and using the applause function on Zoom in welcoming Kerry Bradley. Thank you. Kerry, apologies. I believe you're still on mute.
Oh,
there we go.
There we
Excellent.
go.
Thank you.
No problems. Thanks so much, and good morning, everyone. On behalf of the board, I warmly welcome you today to the launch of Good Health Down South. And I too wish to acknowledge the traditional owners on the land on which we are meeting and pay my respects to the elders past, present and emerging, and acknowledge the many women's organisations and survivor advocates who've spoken out about women's health and gender equality. As you're aware, WHISE is one of 12 women's health services in Victoria. We work across 10 local government areas from South Melbourne down to the Mornington Peninsula and east to Casey and Cardinia. Our region includes a diverse multicultural population. Our health promotion strategies through our integrated health promotion plan have seen the focus on delivery of health promotion programs and services in 3 distinct but integrated areas: gender equality, prevention of violence against women, and sexual and reproductive health. From participating in communities of practice to presenting in a variety of forums, WHISE has been able to reach a large audience and promote awareness regarding these areas. And as such, it is with great pleasure that we're able to meet today to launch Good Health Down South 2021-25, which is built on our previous work and aims to address the systematic health inequalities that occur as a result of our social, political and economic environments that can marginalise and disenfranchise some populations. We know that sexual and reproductive health is a fundamental human right and an essential health component of our physical, mental and emotional well-being, and is vital for overall quality of life. I'd like to take this opportunity to acknowledge the commitment and expertise of our partners and stakeholders in the contribution to the development of this strategy, as well as the support and investment by the department. We have a wonderful range of speakers and performance today, and I'm sure you will enjoy. So on behalf of the board, management and the staff of WHISE, thank you for joining us this morning.
Thank you so much for opening our launch, Kerry, and congratulations on your appointment as chairperson. I'd like to echo Kerry Bradley's words that WHISE is very grateful to be working with all of the partners and stakeholders here today. And I think one of the strengths of this strategy is the opportunity to integrate it with our efforts to prevent violence against women and advance gender equity. The next part of today's launch is an overview of the strategy itself. And I'd like to begin with a bit of a, I suppose, sobering reality of the state of sexual and reproductive health across the Southern Metro region and Victoria. We have an urgent project ahead of us. Sexual and reproductive health, or SRH, requires immediate, coordinated and determined action to change women's health outcomes and advance gender equity. The World Economic Forum estimates that it will take 257 years to achieve our goal of gender equality. But research tells us time and time again that one of the most powerful ways of improving and addressing gender equality is to enhance women's sexual and reproductive health. Expanding and protecting women's autonomy, their control and choice over their SRH outcomes is a key component of this project. Increasing women's access to social, economic, political and cultural resources and power also reduces barriers to accessing SRH care. These principles are applicable to all settings, including highly developed states like Australia. And you need only look at the situation in Texas, where abortion has recently been banned after 6 weeks, at which point most women would not even realize that they're pregnant in order to recognize this. This criminal ban has been condemned by human rights groups as blatant sex and gender-based discrimination and in direct contravention to international law. SRH matters also because outcomes are not improving, not without intervention. In fact, some outcomes are getting worse. Sexually transmissible infections, or STIs, are increasing exponentially. There's been a 220% increase in cases of syphilis in the southeastern suburbs of Melbourne. Since 2017, a rise in women contracting the infection has led to the re-emergence of congenital syphilis in the state. Though some STIs are more prevalent among men, and in particular men who have sex with men, there is a disproportionate impact among women, leading to disproportionate impact among women that should add to the alarm surrounding increased prevalence. Many STIs are asymptomatic among women, leading to delayed diagnosis and can cause cancer, ectopic pregnancy, pelvic inflammation, neurological disease, including deafness and blindness, and infertility. SRH is also important because women's health issues continue to be treated as marginal. SRH also means endometriosis, polycystic ovary syndrome or PCOS, and menopause. Endometriosis and PCOS are chronic health conditions that can severely impact the lives of women, girls, and people affected. These conditions have been and continue to be under-recognised among both the medical establishment and the public, and subsequently underdiagnosed. The delay between the onset of symptoms and diagnosis is on average between 7 to 12 years. 7 to 12 years of living with heavy menstrual bleeding, irregular periods, infertility, painful intercourse, and other symptoms. 7 to 12 years of living with chronic pain that causes absenteeism at work and disruptions to studies and one's personal life. The national plan attributes this delay to the variability of symptoms and the invasiveness of diagnostic procedures. And with due respect, this is only part of the picture. These are influencing factors, certainly, but these factors exist within and are informed by a healthcare system that has downplayed, dismissed, and outright ignored women's SRH issues until very recently, and crucially has normalised women's pain. It is not good enough, and we need to demand better. We need to demand better when it comes to reproductive choices, specifically contraception and abortion. 1 in 3 Australian women will have an abortion in her lifetime. These services are vital to ensuring reproductive autonomy and rights, the human right to decide if and when you wish to have a child and how many you wish to have. It is inconceivable to imagine a gender equitable society without the realisation of full SRH rights. Abortion and contraception uphold the human right to decision-making, autonomy, and dignity. Though abortion has been decriminalised in Victoria since 2008 and protected through safe access zones since 2016, we know that significant barriers remain for women, including cost, geographic accessibility, practitioner knowledge, and attitudes. And for women who are ineligible for Medicare, including some migrant women, or for women who live remotely, including Aboriginal and Torres Strait Islander women, the barriers are exponentially greater. The challenges of SRH healthcare provision have been exacerbated by the COVID-19 pandemic. The pandemic and the necessary pivots towards suppressing transmission of the virus have presented challenges for our work. COVID-19 has created barriers to preventative screening, including cervical screening and STI testing, at times limited the availability of contraception, and limited access to assisted reproductive technology throughout last year. COVID-19 has also undermined access to the full range of reproductive healthcare. While abortion was correctly categorised as urgent medical treatment, restrictions on movement and isolation measures, while absolutely necessary for the pandemic, have had unintended consequences for abortion access. Similarly, the indirect barriers such as costs have been exacerbated, with women being more affected than men by unemployment or loss of income. Additionally, SRH matters for the prevention of violence against women. There's a well-established bidirectional relationship between these two health issues, one that is underpinned fundamentally by gender inequality. And it's not a coincidence that these three strategic priorities are the ones adopted by the Victorian Women's Health Services. Women who experience violence in intimate relationships have poorer sexual and reproductive health outcomes, including inconsistent contraception use, increased risk of unintended pregnancy, poorer maternal and child health outcomes, increased risk of STIs and genital and reproductive tract infections. Violence against women may also impede access to health services, including abortion. Sexual and reproductive health matters, but it matters not just at a federal level in terms of legislation, funding, and research. It matters for us regionally. Just as active living, nutrition, and food security and mental health require localized, place-based responses, so too does sexual and reproductive health. It requires integration into all levels of our health and wellbeing planning, because the social determinants of health don't just impact people at a federal governance or societal level, they impact people at an individual, community, institutional, and structural level. And the organisations that are best placed to identify community need and gaps in service delivery are those on the ground, working directly with communities, such as our partners and stakeholders here today. Sexual and reproductive health is vitally important for women and for the Southern Metropolitan Region. This is why it gives me great pleasure to present to you all here today, Good Health Down South 2021 to 2025, our second strategy for sexual and reproductive health in the Southern Metropolitan Region. The strategy is our collective contribution to tackling the so-called wicked problems of women's sexual and reproductive health. Good Health Down South 2021 to 2025 builds on the successes of its predecessor. From 2018 to 2021, the Good Health Down South partnership developed and implemented a massive suite of work, including, but not limited to, a toolkit for Ida Hobbit Day, an advocacy piece on the experiences of women from the African diaspora communities, 10 submissions to councils to inform their municipal health and wellbeing planning, the development of data snapshots, support for other programs, annual forums and webinars, the implementation of health literacy sessions for the South Sudanese women's community in Dandenong, and capacity building for the provision of medical abortion across the region, and imminently the establishment of the medical abortion clinic through Peninsula Health's SRH hub. It will be a challenge to improve upon this enormous suite of achievements, but we can do it. And we can do it because this strategy is ours. It's held collectively and has been developed through extensive consultation. It reflects the community needs, existing and future areas of work, and organisational strengths of the region. It was developed through a survey completed by 26 stakeholders, semi-structured qualitative interviews completed by 38 organisations and over 50 individual stakeholders. In total, this represents contributions from at least 44 distinct organisations across Victoria and the Southern Metropolitan Region. The draft strategy, action plan, and evaluation framework were all presented to partners and stakeholders at two key milestone events, the Roundtable in September and the Think Tank in October, and refined through an iterative process highlighted here and in the strategy's roadmap. Our strategy is underpinned by key principles or values jointly held by the Good Health Down South partnership. Our strategy is informed by an intersectional and social determinants of health framework and is focused on primary prevention. We take a life course approach and aim to work with the Promoting Respect and Equity Together partnership for the prevention of violence against women. We also seek to centre and elevate the voices of women and priority populations and engage men and boys for the improvement of women's sexual and reproductive health outcomes. Good Health Down South has a vision of a Southern Metropolitan Region where everyone enjoys optimal SRH. To achieve this vision, the strategy articulates 3 strategic priorities and multiple objectives. The first is integration and prioritisation. Good Health Down South seeks to integrate SRH promotion with other health and wellbeing priorities, in particular, the prevention of violence against women. This strategic priority refers to the prioritisation of and commitment to SRH in general health and wellbeing planning within local government, community health organisations and other health promotion agencies. We seek to increase the capability of the regional workforce to address SRH by increasing and strengthening and broadening the number and type of organisations involved in our partnership, as well as those that have the capacity to integrate SRH into their health planning. Our second strategic priority is equitable access. Access to high quality, inclusive and affordable health services is in and of itself a key social determinant of health and is influenced furthermore by others, including income, employment and job security, access to housing and welfare, the social environment, social inclusion, and experiences of discrimination. For health services to be truly equitable, they need to be safe, affordable, timely, physically accessible, culturally sensitive, and patient-centered, and free from stigma and discrimination. Barriers to accessing healthcare persist and can include economic or financial barriers, social, geographic, and legal barriers. Good Health Down South seeks to increase equitable access to healthcare services by ensuring that primary practitioners have the capacity to provide SRH care. We also seek to improve organisational capacity to provide services that are culturally appropriate and inclusive for priority populations, including Aboriginal and Torres Strait Islander people, LGBTIQ+ communities, and people from culturally and linguistically diverse communities, which our guest speaker, Dr. Adele Murdolo, will speak to shortly. Our third priority is health literacy. This strategic priority is targeted at enhancing sexual and reproductive health literacy at a community level by working with organisations and providers to increase the effective dissemination and promotion of evidence-based SRH information. Literacy comprises two important and interconnected components. One being the knowledge and skills to understand and utilise health information and navigate the healthcare system. The second being the health literacy environment, including policies, processes, and the distribution of health information that affect an individual's capacity to engage with the healthcare system. Health literacy has a profound impact on SRH outcomes. Knowledge of SRH issues, when coupled with access to resources and services, allows people to integrate preventative health behaviours and access timely testing and treatment, thus reducing the impact and prevalence of disease. In addition to increasing the dissemination of SRH information, Good Health Down South 2021 to 2025 seeks to enhance regional practitioners' knowledge and capacity to provide respectful relationships, sexuality, and affirmative consent education to prevent sexual violence and coercion. The strategy also recognises priority populations who experience a disproportionate burden of poor health outcomes due to structural inequities and limited access to services. And it's important to emphasise here that this is attributable to historic and contemporaneous oppression, both structural and interpersonal, that has impacted the social determinants, including wealth and income, access to employment, safe housing, food security, and access to health services. This really puts the onus on the political, economic, social, and cultural institutions and structures, including the healthcare system, to address the inequalities experienced by priority populations. It is unconscionable that in Australia today, people continue to experience poorer health outcomes based on their sex, gender, race, socioeconomic background, age, or disability. Good Health Down South seeks to work intentionally and meaningfully with organisations that represent these populations, including the Multicultural Centre for Women's Health, the Centre for Multicultural Youth, Monash Refugee Health, Jewish Care and others, and we thank you all for providing your expertise to the development of this strategy. How will we know if we've succeeded in achieving our vision of a region in which everyone enjoys optimal SRH? Our partnership has developed a rigorous evaluation framework that will monitor and assess the implementation of the strategy at an outcome, objective, and action plan level. It's essential to collect evidence about the efficacy of a program or policy in order to identify unintended outcomes, opportunities to improve and enhance practice, and increase the reach of a program or policy and justify the use of resources. This is the first time that our strategy incorporates a detailed evaluation framework and will require a commitment from partners and stakeholders to participate in quantitative and qualitative evaluation and data collection. Evaluation will be a major focus of the strategy, but so too is the growth and strengthening of the partnership itself. Effective health promotion is effectively about relationships between health systems and policymakers, organisations and communities. SRH promotion is no different. Our strategy and action plan is designed to build and expand the partnership in terms of the number and diversity of the organisations and the types of sectors that are represented. By the end of the 4-year period, I'm confident that we can make the Good Health Down South partnership the largest and most effective partnership for women's SRH in the state. Our strategy and action plan are ambitious. We can do it, but only in partnership with all of you. Building and strengthening and expanding the partnership is a key priority for the strategy, catalysed by quarterly learning forums, which will provide an opportunity for professional development, knowledge brokering and networking. Additionally, Good Health Down South will have quarterly network meetings to discuss and review the progress of our action plans, provide service updates, discuss trends in data and new evidence. This will be supplemented by working groups to operationalise and evaluate the Year 1 and 2 action plan. At the top of this governance and implementation structure, you'll note the advisory committee, a new committee that will work with WHISE's CEO, Kit McMahon, to oversee the strategic direction, risk mitigation, and alignment of the Good Health Down South strategy with efforts to prevent violence against women. I'd like to conclude by thanking the many organisations and individuals who made possible the publication of this strategy. You've all been extremely gracious and generous in providing Good Health Down South with your time and expertise, your knowledge and connections, and I hope that all of your efforts are reflected in the final strategy that we're launching here today. I'd also like to extend a most heartfelt thanks to my colleagues at WHISE. The development of a strategy such as this requires a skilled and dedicated team, and I'd like to acknowledge you all, in particular, my manager, Zoe Francis, and the CEO, Kit McMahon, as well as the Victorian Government and Department of Health for their ongoing support. I commend this strategy to you, our partners and stakeholders, and urge that it be used as a basis for partnership and action to improve women's SRH into the future. Thank you very much. It gives me great pleasure now to welcome our performer, Alice Tovey, who I assume has arrived.
Hello, everyone. Can everyone hear me? Give me a yell if you can't.
Thank you so much for joining us,
Thank
Alice.
you.
Alice Tovey will be providing our musical entertainment for this morning's celebration. She is a singer, songwriter, screenwriter, and outspoken feminist activist. She's toured award-winning shows with her co-writer and musical director, Ned Dixon, to critical acclaim. A true double threat, she holds a Bachelor of Classical Voice from the Melbourne Conservatorium of Music and a Master of Screenwriting from the Victorian College of the Arts. Her inaugural show, Malice, earned her an Adelaide Fringe Award for the Best Emerging Artist at the Weekly Awards, and she's also been nominated for a Green Room Award for Best Original Songs. Alice lives in Melbourne with her fat cat, Hudson. Alice, I too have a chunky cat, Mo, who is locked out of my room presently.
Amazing.
Please join me in welcoming Alice to the stage. Thank you, Alice.
Good morning, everyone. How are we? Good. I'm seeing a lot of claps. I'm seeing a lot of thumbs up. Zoom gigs are still here, but luckily we can all get out of the house a little bit more. But at the moment, welcome to mine. I apologize in advance. I have a partner on another Zoom call. So if you hear them, it's not my background singers. It's my partner doing some corporate strategy. But it's wonderful to be here. Thank you so much for having me. I'm going to sing a few classic feminist bangers. So no rude words or swears like I usually put in my songs today. We're going to stick to some disco hits. So without further ado, here we go. And again, if you can't hear me at any point, just stop me and I will fix the tech. Oh, 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 oh. Oh, 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 oh. I'm every woman, it's all in me. Anything you want done, baby, I do it naturally. Oh, oh, oh. I'm every woman, it's all in me. I can read your thoughts right now, everyone from A to Z. Hey, I can cast a spell of secrets you can tell. Mix a special brew with the fire inside of you. 'Cause anytime you feel danger or fear, I will appear. 'Cause I'm every woman, it's all in me. Anything you want done, baby, I do it naturally. Oh, oh, I can sense your needs like rain into the seeds. I can make a rhyme of confusion in your mind. And when it comes on down to some good old-fashioned love, that's what I've got plenty of, baby. 'Cause I'm every woman, it's all in me. Anything you want done, baby, I do it naturally. Yes, I do it naturally. I ain't bragging, 'cause I'm the one. You can't stop me. Oh, it just can't be done. And don't bother to compare to me, babe, because you know that I've got it. 'Cause I'm every woman, it's all in me. Anything you want done, baby, I do it naturally. Oh yeah, 'cause I'm every woman, it's all in me. I can read your thoughts right now, everyone from A to Z. Oh, 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 oh. I'm every woman. I'm every woman. Yes, I'm every woman. I'm every woman. I'm every woman. I'm every woman. Thank you, everyone. Oh, it's so nice to see clapping faces on the screen. Oh, this is a lot of fun. Thank you again for having me. It's just such a pleasure doing gigs. I, like many people, like many artists, I've been in my house a lot of the time, still am, but it's great to be performing for such wonderful people, doing such excellent work for women and gender diverse people. It really does mean the world. All right, so let's kick on. with a request from Laura. I'm very excited to play this one. It's a bit of a classic. I have a feeling that everyone's going to know the words. Feel free to sing along in your house. You're on mute, so you can really let it rip. I am woman, hear me roar, in numbers too big to ignore, and I know too much to go back and pretend, 'cause I've heard it all before, and I've been there on that floor. No one's ever gonna keep me down again. Oh yes, I am wise, but it's a wisdom born of pain. Yes, I've paid the price, but look how much I've gained. If I have to, I can do anything. I am strong, strong, I am invincible. I am woman. You can bend, but never break me, 'cause it only serves to make me more determined to achieve my final goal. And I'll come back even stronger, not a novice any longer, 'cause you've deepened the conviction of my soul. Oh yes, I am wise, but it's a wisdom born of pain. Yes, I've paid the price, but look how much I've gained. If I have to, I can do anything. I am strong, I am invincible. I am woman. I am woman, watch me grow and see me standing toe to toe as I spread my loving arms across the land. But I'm still an embryo, the best line ever in a song, with a long, long way to go until I make my brother understand. Oh yes, I'm wise, but it's a wisdom born of pain. Yes, I've paid the price, but look how much I've gained. If I have to, I can do anything, because I'm strong, I am invincible. I am strong, I am invincible. I am woman. Thank you all so much.
Wow, please join me in putting your hands together and thanking Alice Tovey for a very moving performance. Thank you so much.
Oh, it's my absolute pleasure. Thank you all so much for your lovely claps and your lovely heart emojis. It really does. It's made my absolute morning. I hope you have a lovely rest of your day. And again, thank you for all the amazing work that you do for so many, again, women and gender diverse people. We are strong, invincible, and we are women. So thank you
so much, Alice.
Bye.
Just beautiful. Wow. That is tough to follow. I probably should have situated her at the end. That was an incredible performance. But I would now like to welcome my equally incredible colleague, Kat Nurse, to the floor. Kat is a health promotion officer for the primary prevention of violence against women and the project lead for the renewal of our regional strategy, promoting respect and equity together. Kat will be providing a brief announcement about an upcoming event. Thank you, Kat.
Thank you, Laura, for that lovely introduction. And wasn't that just amazing? Listening to Alice, just fantastic. And it comes off so well as well. Even in the Zoom environment, you really can kind of feel that emotion when she was singing. And I'm sure her partner enjoyed having that background music in their strategy planning activities. So good morning to everyone who is joining us in the Zoom room today. It's lovely to see so many both familiar and new faces. As Laura has alluded to, we have been very busy at WHISE evaluating and consulting with stakeholders in developing both the Good Health Down South and Peeville regional strategies in conjunction with each other. So it's been a very busy time. But what is great is we've heard from partners, and as Laura mentioned, there is really an appetite for demonstrating and highlighting the intersections between the two strategies. We know that sexual violence and reproductive coercion are in themselves forms of violence against women, and they have huge effects on the health and well-being of those women. By working in collaboration across the two strategies and addressing primary prevention initiatives such as consent, resources, and workforce capacity building, we can work to improve gender inequities and women's health outcomes across the SMR. So we welcome all of you in the room today to join us again next Wednesday, as it says there on the screen, on the 1st of December for our Promoting Respect and Equity launch. Promoting Respect and Equity Together launch. It's at 3 p.m, so it's an afternoon launch. And like this launch, we have a fabulous array of talented women speakers and a performer in the lineup, including a mother-daughter duo, Janine and Jessica Sanders. Janine and Jessica Sanders are both accomplished gender equality advocates and write fabulous books for children and young people around gender equity, embracing inclusivity and diversity, body safety, consent, and respect. So to hear more about the new gendered violence prevention strategy, please use the link that Zoe's going to put into the chat to sign up and join us at our launch next week, or you could just use your phone to scan over the good old QR code that we're all so familiar with. That's on the screen there, and that'll just take you directly to the Eventbrite registration. So thank you very much and look forward to seeing you next week. Thank you, Laura, and on with the presentation.
Thank you so much, Kat. The next item on the agenda for our launch is an address from the outgoing Mayor of Mornington Peninsula Shire, Mayor and Councillor Despi O'Connor. Councillor O'Connor was elected to the Mornington Peninsula Shire Council in 2020 and represents the Briars ward. Councillor O'Connor was elected as Mayor in 2020 and is the appointed representative on the Council's Literacy Advisory Committee, the Interface Councils, the Municipal Association of Victoria, South East Melbourne, the Mornington Peninsula Cemetery Trust, and the Local Government Mayoral Advisory Panel. The Victorian Government has also appointed Councillor O'Connor to its 2021 Local Government Mayoral Advisory Panel. She has been an active member of her local community for many years, including being the founder and president of the Mount Martha Basketball Club, patrol member and captain of Mount Martha Lifesaving Club, chief instructor of the Mount Martha Lifesaving Club, and assessor for the Bayside Lifesaving Clubs. Councillor O'Connor is passionate about a range of local issues, including recognising their diverse population and ensuring equity for all residents of the Mornington Peninsula Shire, including educating others about the traditional owners, the Bunurong people of the Kulin Nations, their culture and resilience in the spirit of reconciliation. Councillor O'Connor has also been a vanguard of sexual and reproductive health promotion and gender equity in local government, most recently by supporting Sexual and Reproductive Health Week's annual social media campaign. Not only is Councillor O'Connor an accomplished local government professional with a prolific resume, but she's also a very adaptable and flexible mother who is joining us from the car. Please join me in welcoming warmly Councillor O'Connor.
Thank you, Laura. Yes, it's a little bit flexible today. It's been a little bit stressful, but helping my son out with some teeth issues. Anyway, we're all good, and I didn't want to drive home, Laura, because I don't think I would have made it in time. So I'm still here. Thanks for inviting me to speak today. This is a subject very close to my heart, as it's all about agency and the well-being of women. Hearing from the speakers today, I'm reminded that the health of women still needs more discussion. Through our lifetime, a woman's body undergoes more change than their male counterpart. Our bodies are judged and shamed throughout our lives. And to truly give women agency, they'll need to understand their bodies and love what it is capable of, as well as ensure that they can access support when they want or need it. It must be informed and it must be easily accessible to them. Through organisations such as WHISE, we can ensure that information about affirmative consent, sexual health and reproductive rights is disseminated appropriately. I thank you for taking the lead and ensuring that it's available to women no matter who or where they are. Local government also has a role to play in this. The health and well-being of our community is a top priority for us. This includes the physical, mental and emotional well-being of all women who call the Mornington Peninsula home. We know that sexual and reproductive issues are big factors in women's health, as is gender equality. And as a feminist and a local councillor, I believe one of the most important things I can do is advocate on behalf of my community and show leadership when it comes to this issue. And when someone to push it underground, it is my role to lean in, not out. Some of you might be aware that back in September, our council shared your wonderful messages about sexual and reproductive health through its social media channels. This included clearly still taboo topics of contraception, menstrual health, abortion, pleasure and sex education. To my surprise, it caused a little bit of a stir. In fact, the post became our second top performing Facebook post ever and reached nearly 17,000 people. I thought that was absolutely fantastic. As you can imagine, I was delighted by this, that we'd achieved and we'd managed to reach so many people with this positive message. Quite a few of the comments were either humorous or appreciative of a bit of lightness during lockdown, but sadly there were others that expressed outrage or even disgust. And we all know that the latter is a measure of resistance and backlash. The message I sent back to our community in response to this was simple. We're committed to gender equality and women's health. Open and honest discussions about sexual health, consent and respectful relationships are a vital component in preventing violence against women. And part of our commitment to gender equality and women's health involves promoting Sexual and Reproductive Health Week in partnership with WHISE. I was comfortable with that messaging in your campaign, aligned with the Victorian Government's Health and Wellbeing Plan, which prioritises improved sexual and reproductive health. As a woman myself, growing up with far too little information on this topic, except for the text "Every Woman," written by a man, which I have since thrown away. Where was Kaz Cook when I needed her? I myself found it hard to navigate puberty and womanhood. A daughter to an English descent a female and a Greek dad. It was actually quite difficult in my home. And this caused much distress and shame, as I could not understand some of the issues that my body was having, and I had no one to talk to about that. And the issues that I had included, and not limited to, polycystitis, burst cysts, heavy bleeding, including heavy bleeding postpartum, 2 weeks postpartum, which even as an adult woman, I still had no one to talk to about that. Many of the topics raised in the campaign were also supported by our own health and wellbeing plan for the community. With some people reacting with anger or disgust at our Facebook post about sexual pleasure, it's clear that the mission to bring about positive cultural change is far from over. Because of course, it's not only men that deserve pleasure during sex, it's also women. You only have to look at what's happening to our young people in terms of exposure to harmful, misogynistic online pornography to know how big this task is. So many of our children, boys and girls, are learning about sex from watching pornography. As a result, they are developing some pretty skewed ideas about what it's all about. Remember the days when we looked up sex? It was in the dictionary. It wasn't online. Yeah, I can hear a few chuckles, even with mutes on. And those mistaken beliefs and attitudes towards sex can be the cause of much unhappiness over the course of our lifetimes. Rather than stand by, helplessly watching this train wreck unfolding, WHISE is among those who is trying to do something about it. And I support this 100% and will be there for you the next time as well. For all women and girls in our community, knowing that you have a right to reproductive and sexual self-determination really matters and is a message that needs to be continually reinforced to counteract the negative messages that women are constantly bombarded with. We know that the sexual objectification of women can have the effect of dehumanising them, leading to further inequality. And there is solid research that tells us that gender inequality is one of the key drivers of family violence. Women in our community are experiencing all forms of violence far too often, including physical, emotional and psychological, verbal and sexual violence. Victorian Police reported 2,211 family violence incidents on the Mornington Peninsula in 2019-2020 alone, and that's just the tip of the iceberg. Tackling this topic is one of the biggest things we can do to make a difference to the lives of women and girls. We know there is much we can do as individuals and as a community to help to change the attitudes and ways of thinking that enable this family violence to take place in the first place. Which is why Mornington Peninsula Shire Council has a gender equality strategy. And I'm proud that we're one of the first councils in Victoria to adopt such a strategy, which seems totally ridiculous, doesn't it, in 2021? And we're now busy putting this into action. As part of the strategy, our council has held several webinars this year for men and boys in our community, aimed at deconstructing the traditional masculine stereotypes and shining a light on how harmful, outdated gender roles can be for both men and women. And I've been lucky enough to be involved in those, and just recently last week presented at Padua in front of 400 young men and women who are in year 10. We've also taken action to ensure gender equality across all our areas of our organisation, such as recruitment, training, promotion and leave. Before I finish, I'd like to thank you again for inviting me to this event. I really believe in what you are trying to achieve. So I'd like to say to everyone at WHISE, keep up the good work, stay strong. Please don't ever underestimate the positive impact that you have, but also thank you for your support of me during that most difficult time. It actually did help to buoy me through that. Because as a community, we cannot really fully realise our human potential until we have a culture that respects women and does not place any gender-based barriers to their health and happiness. Thanks so much for having me, Laura and Kit and Zoe, and to all my officers who actually supported that campaign. Thank you so much, Hilary, Andrew and Katie. They really led the way. And to my fellow councillors, Councillor McCafferty and Councillor Race, who were super supportive of me, trying to deal with that outpouring of I'm not sure what, backlash and resistance. And also to my CEO, Mr. Baker, who also supported me during that time. But I think we came out the other side all right, but it does certainly say that we need to have more of these conversations. Thank you.
Absolutely. What a powerful address. Thank you so much, Councillor O'Connor. I could not agree more that Sexual and Reproductive Health Week highlighted at a community level that sometimes perhaps I'm not conscious of, living in my feminist milieus, that there is still such a way to go, and that instead of being cowed by the backlash, I think Councillor O'Connor and her team demonstrated the need to demonstrate leadership, to push back against that resistance and to continue putting out those messages that make a real difference. It was interesting that one of the comments from an opponent during the campaign was that Mornington Peninsula Shire must be sharing this campaign because now there's a bunch of women at the helm of Mornington Peninsula Shire. It's full of these women councillors. And I wanted to kind of ironically give that one a like, because while I'm not sure the opponent's comment was intended as a compliment, that is absolutely how I took it, that there is no doubt that the advocacy and leadership for campaigns such as this stems from women, strong, confident advocates like Councillor O'Connor, and I thank her not only for that powerful presentation, but also for her leadership during Sexual and Reproductive Health Week, and to her team as well, Hilary, Andrew. I'm very much looking forward to working with you all next year. Our final presenter for today's launch is the Executive Director of the Multicultural Centre for Women's Health, Dr. Adele Murdolo. The Multicultural Centre for Women's Health is a national women's health centre run for and by migrant and refugee women. Dr. Murdolo is a second-generation Italian migrant woman. So am I, Dr. Murdolo. Benvenuti. I'm sure we have many passata and biscotti recipes that we could trade. She has a PhD in history and women's studies. She's a passionate speaker and advocate for building the status of migrant and refugee women through research, practice, and policy, and has a prolific list of papers against her name. Her research and advocacy around violence against women, women's health, in particular sexual and reproductive health and mental health, and the history of feminist activism in Australia. Dr. Murdolo is also an honorary senior research fellow at the Centre for Health Equity at the University of Melbourne. Please welcome Dr. Adele Murdolo.
Grazie Laura, sono contenta di essere qui. So thank you, Laura. I'm so happy to be here. Thank you to WHISE for the invitation. It's a real honour. Now, Laura, I would like to share my screen if that's possible.
Absolutely.
I've got a presentation.
Absolutely.
Thank you. So just bear with me while I work out how to do this. And so I believe you can see my screen now.
I can.
Fantastic.
Thank you.
Okay. So again, thanks so much. The strategy looks amazing. Congratulations to WHISE and everybody who's participated in it. And we really look forward to continuing to work with you on that. So I'm going to begin by acknowledging that I live and work on the lands of the Wurundjeri people of the Kulin Nation. This land was never ceded, and I would like to pay my respects to elders past and present, as well as particularly acknowledge any Aboriginal or Torres Strait Islander people who are sharing this seminar with us today. I'm speaking from the Multicultural Centre for Women's Health. We're a Victoria-based migrant and refugee women's organisation. So all the direct work that we do with women is based in Victoria, but we do also deliver some research and advocacy training and other types of projects on a national level. So what I'm here to talk about today is really, well, it's visas, vulvas and voice, as I mentioned in the beginning of the presentation, but essentially I want to take a look at a new data report that MCWH has put together, and then think about what some of the actions might be that organisations can take to improve the health and wellbeing of migrant and refugee women, specifically focused on SRH. So the MCWH's data report basically collected and summarised research that was available to us about migrant and refugee women's sexual and reproductive health. So it wasn't comprehensive. We weren't able to find data on everything. So endometriosis, for example, we don't know what the rates of endometriosis are, particularly amongst migrant women, but there was some data that we were able to collect and understand. And we were able to come up with some quite interesting findings. So overall, the data from our sexual and reproductive health report found that migrant women were more likely to experience barriers to their SRH health care, And that included things like antenatal care and abortion care. They were less likely to access health information that was evidence-based, that was in their preferred language, and that was culturally appropriate. And perhaps we saw the impacts of that very, very clearly throughout COVID. But that same principle applies to sexual reproductive health. They're more likely to experience prolonged and severe family violence. So even though we don't have any disaggregated information about migrant and refugee women's prevalence of family violence, we do know that it is more likely to be more prolonged and severe. And this is because the barriers to accessing support. And then finally, we know that migrant women are at greater risk of poor maternal and child health outcomes, and they do have higher rates of perinatal mental health issues. I'm going to take a look at two key issues, just as a little snapshot, because we don't have time to cover the whole report, but I do invite you, I know the link's in the chat, so I invite you to take a look at the whole report. But when we look at contraception use, one of the things we find is that not only are there lower rates of contraception use amongst people born in non-English speaking countries, we also know that there are different technologies used. So the most used method amongst those born in non-English speaking countries is condoms, whereas amongst people born in Australia, it's the pill. So there's different, there are lower levels, as you can see, 60% of people use contraception who were born overseas in a non-English speaking country, compared with 69% of people born in Australia and 77% of people born overseas, but in English speaking countries, which is interesting in itself. So lower levels and also different trends. So I guess that's really a flag that we need to really do this work differently amongst migrant communities. The second little snapshot that I want to provide is looking at maternal and child health outcomes. And there are three key red flags, I suppose, that we've got. The first one is that mothers who are born in non-English speaking countries are less likely to access antenatal care in the first trimester. So the Australian standard is within the first 10 weeks, and mothers who are born overseas in a non-English speaking country, only 70% of them will access antenatal care in the first trimester, compared with mothers born in Australia who are at 76%, which is still not ideal, of course. We do have a long way to go when it comes to antenatal care for everybody, but migrant and refugee women, the rates are lower over time and globally as well. So it's not just in Australia, and there are quite important reasons why, and a lot of work that we could do to bring those rates up. So at the other end, and one of the consequences of not having adequate antenatal care is, of course, in birth outcomes. So mothers who are born overseas are more likely to have an instrumental vaginal birth or a caesarean section. So compared with Australian-born mothers, the rates are 14.3% for instrumental birth, compared with 11.7% amongst Australian-born, and then caesarean section rates, there's about a 38.1 compared with 34.9%. Concerningly, stillbirth rates are higher amongst women who are born overseas. So the general rate in Australia is, for mothers born in Australia, is 6.7, sorry, I'll say that again, 6.7 deaths out of every 1,000 births, which again is too high. But amongst women born overseas, the rate is 7.3 deaths in 1,000 births. When you start to look at some of the individual regions of birth, you start to see a really alarming picture. So for women who are born in Melanesia, the rate is 24.3% deaths in, 24.3 deaths in 1,000 births. Central and West Africa, again, very high, and North Africa, 16 out of 1,000 births. So we've got some pretty serious issues there, showing some quite poor birth outcomes and quite poor, child outcomes as well. Now, again, it's a snapshot. You'll see a lot more in the report itself. But now I'd like to really talk about some of the social issues. And I know that the plan that you've put together, your strategy, is really focusing on social determinants and an intersectional approach. So I really want to have a look now at what those social issues might be and how we might take an intersectional approach to address them. So there are 3 issues there that I've identified, but there are many, many more. So the first one is visa, the second one is vulva, the third one is voice. And the question for me is, you know, even though these issues are happening in the health system, the causes happen outside of the health system. So we really need to be looking at what the causes for these poorer outcomes are. But even though some of the solutions are in the health system, today I'm going to look at those that are sitting outside. So the first one is visa. I'm sure that many of you would already be aware that there is a bit of a 2-tier system in Australia when it comes to healthcare. And for women on temporary visas, they're not covered by Medicare. So they have to take out health insurance that covers some of their costs but doesn't cover all of their costs. And for international students in particular, there is there's a clause within the deed of the health insurance deed with the federal government that says that health insurance companies don't have to provide pregnancy-related, don't have to cover pregnancy-related costs for the first 12 months. So that's really, that's quite problematic for international students in the first 12 months. But there are other exceptions in healthcare, in health insurance, as we know. And so this 2-tier system means that for temporary migrants, health access to health services is reduced and limited and confusing and complicated and costly. The second effect of it is that it really questions migrant women's belonging more generally. So generally speaking, people don't ask a person if they're temporary or if they're permanent when they first, come to your service. But there becomes a sense that migrant women more generally don't belong in the same way that a person who's born in Australia belongs. And this, of course, is exacerbated for women of colour. Often asked, but where are you really from? And the other impact that this has is that it embeds a user pays ideology into the health system. So at the moment we have a 2-tier system, but we know that down the track it's going to become a 3-tier and 4-tier. And this sense that you really should be paying for your own healthcare is entrenched and then goes into other systems as well. So the next key issue is vulva, and this one's really about stereotyped depictions of migrant and refugee women. And I'll just pick 2 issues today. One is that they do become represented as more passive and unable to navigate the system. But the second one is that migrant women become reduced to their biology or their culture, so that people focus on what it is about them that creates ill health, rather than looking at what it is about the system that is, problematic and needs to be changed. So we might focus, for example, on migrant women's lack of English and say that it's because they lack English that they don't access the health system, rather than looking at how the health system really needs to boost its interpreter use and get that sorted before, looking individually. So finally, the third issue is voice. And really that question about who speaks for whom. So stereotypes of migrant women as passive and silent, which obviously they're not true, but these are the stereotypes, really engenders an attitude towards migrant women that they're not able to speak for themselves. And so other people need to speak on their own behalf. So even when people do within organisations want to work on migrant women's health issues, they might end up speaking on behalf of migrant women. The image that I've put into this slide, and this is something that you might like to try at home, Google diverse women. And what you'll often find is an image like this one that I've put on this slide, which is a group of quite diverse women, so coming from different ethnic backgrounds. But you'll find that the white woman is often at the centre of the image. And that's entrenched in our thinking. And it really is something that we need to identify and challenge as we start to do this work. The other thing we need to understand is about systemic inequity and the perpetuation of race and gender hierarchies in the labour force, and in that inequity is often replicated within our own organisations. So when we start to, we think, okay, we want to address migrant women's health, we really want to, kind of bring some migrant women forward in our organisations to do this work. But where are they employed? They tend not to be employed in decision-making roles, and they tend, to be doing really that face-to-face work and not in our leadership. So this is something that we really need to think about. So how do we centre migrant women's voices, and how do we support and foster and create a platform, not only for their voices, but for their leadership? So finally, I'm coming up to my last slide, and I know I've gone a little bit over time, but finally, 6 steps, 6 little tips to start to work towards an intersectional approach to SRH in our organisation. So the first thing is always think about how you can transform systems and structures, and not so much about how women might need to change in order to use your service. Challenge race and gender hierarchies. So if you do notice in your organisation that there's a lack of migrant women in leadership positions, maybe there's something that you can do about that, or the leadership can do about that. Challenge the stereotypes and create new images. Rewrite dominant narratives about migrant women. Centre migrant and refugee women's voices. So when there's an opportunity to speak, perhaps you can make sure that your platform includes migrant women as well, and build migrant and refugee women's leadership more broadly, as well as in your organisation. So thanks so much for the opportunity to speak at this launch, and congratulations to WHISE for the great work that you're doing.
Wow, thank you so much, Dr. Adele Murdolo. Please join me in offering some virtual applause. That was absolutely incredible, and highlighted, I think, some very disturbing trends around stillbirth and access to healthcare in the system for SRH. I think one thing that really struck me was the uptake of condom use instead of other potentially more effective, at least in preventing pregnancy, types of contraception. And I think potentially what that speaks to is that condoms are available virtually everywhere instead of exclusively through the healthcare system, like the contraceptive pill or IUDs. And I think the project and the onus, as Dr. Murdolo said, is on all of us here to make sure that we're not only platforming and elevating migrant and refugee women's voices, but to make sure that it's a key focus and project of the strategy, not simply a kind of tokenistic add-on, as it so often is. So thank you so much for that very powerful introduction. And WHISE is absolutely delighted to continue working with your fantastic team, including Maria, Manisha, and Joyce at the Multicultural Centre for Women's Health going forward. You guys do absolutely amazing work. So that brings today's launch for Good Health Down South almost to a close. Before I say a few final words, I'd just like to highlight that the next step, now that we've launched this strategy, is of course to operationalise it. And we're scheduling our first network meeting for the Good Health Down South partnership for Tuesday, the 1st of February, 2022. I don't know if anyone else is alarmed by the fact that we're almost in 2022, but we are, at 10 a.m. And I will also be circulating the evaluation report from the first iteration of the strategy 2018 to 2021 shortly, as well as the year 1 and 2 action plan for 2021 to 2023, which was also developed in consultation with partners and stakeholders. This sort of brings, oh, sorry, I'd just like to say my contact details are displayed on the screen. If anyone has questions, comments or feedback about the strategy or today's launch or our work in sexual and reproductive health more generally. But finally, I'd like to thank you all once again, not only for attending today, but even more significantly for your ongoing investment into women's sexual and reproductive health. We have an ambitious project ahead of us, but I'm confident that through our combined efforts, we can make the Southern Metropolitan Region a statewide leader for women's SRH. Thank you, stay safe and be well. And if you'd like to stick around for a chat, I will stop recording and we can have a virtual scone. But otherwise, I will see you soon.